Tenakoto Katoa, Call Richard Edwards Aho. Welcome to this Aspire 2025 seminar today. And it's my great pleasure to welcome Professor John Samet. Particularly welcome the people who are videoing in. I think there's quite a few who are online today, so welcome to all of those people. I think we had one person from Canada. I don't know whether they called up. Nadia, I think it was. Professor Samet's based at the University of Southern California, where he's chair of the Department of Preventive Medicine. And I think he's one of those people who it really is difficult to do his career and CV and so on justice. So I won't attempt to do all of that, but suffice it to say that he is a leading tobacco control scholar and researcher, but also a leading epidemiologist in cancer epidemiology and environmental epidemiology. He's done some of really groundbreaking research in many fields over 40 years. In terms of tobacco control, he set up the Johns Hopkins Global Tobacco Control Research Center, and he was there for 14 years before moving to Southern California. And he's been involved in many aspects of tobacco control within the US and globally, and including being involved in some of the big litigation trials in the US. And more recently, he's been working on the Tobacco Regulatory Science Program funded by the NIH, and has also been chaired the Tobacco Product Scientific Advisory Committee of the US Food and Drug Administration. So he's a very eminent person within the tobacco control field. And also he's been editor or senior editor of many of the US Surgeon General reports since 1984. And those documents are some of the most influential tobacco control documents in the world. So it really is a great privilege for us to welcome Professor Samet here today. And he's going to be talking about tobacco control in the US and some possible lessons for New Zealand.
Thanks, Richard. And it's very nice to be here. And I congratulate you on your ambitious goal of Smokefree 2025. I notice this crowd is a little more right than left. And more up than down. It's like talking to the medical students who actually refuse to sit in the first 3 or 4 rows. There's this huge gulf between whoever is talking and them. So what I've proposed to do is sort of laid out here, but actually what I'd really like to do is talk about things that are useful for you as you look at your own policies and how to move, and what lessons might be learned from what we are doing and not doing in the United States. You might notice that I did put a question mark at the end of lessons for New Zealand, because some things may be transferable and some things that our FDA is doing, you may look back in amazement and say we would never do that. So, but I will be telling you about what we are doing. So when I talk about tobacco control and sort of the tobacco epidemic, I have to say now I look fondly, if you will, back at the good old days when the world was simple. There were combustible cigarettes and a few other products, but mostly we were concerned about the health consequences of combustible cigarettes. And we quickly identified many adverse health consequences. And here's the revered epidemiologist Richard Dahl, who did much of the early work, talking about how much we had learned about the health consequences of smoking from simple epidemiological studies. And then this question of what we had done with the evidence. So this is a plot of tobacco consumption per adult in the United States across essentially the last century. And I'm going to put onto that the rise of lung cancer up to about 1950 or so. And that's very much where the story started. Yes, there was recognition that lung cancer was a rising problem before 1950, when a number of seminal studies were published. But it's sort of the mid-century, 20th century, where the story of tobacco control begins. There were efforts to control tobacco use before, some driven by the temperance movement, for example, in the United States. But the science-driven evidence that said tobacco control would reduce disease begins roughly in about 1950. And then these case control studies were published of smoking and lung cancer, very simple in design. The second one down, which here was done by Ernst Winder as a medical student at Washington University. He teamed up with Ewerts Graham, a thoracic surgeon, to study Graham's patients and find out about their smoking and make comparison. And a powerful answer emerged. Winder went on to paint cigarette smoke condensate on the backs of mice and produce tumors. And by 54, we had the results from prospective studies, studies where smokers and non-smokers were followed, mortality rates from lung cancer and other diseases calculated, and quickly there was evidence. Dahl went on to do the British doctors' study. Now, importantly, what did the tobacco industry do? What would any responsible industry possibly do if their product was killing people? They might stop making the product. But what did the tobacco industry do? They initiated a campaign of fraud, denial, and creating doubt that is now well documented. The book, The Golden Holocaust, by my friend Robert Proctor, historian at Stanford, eloquently tells the story, drawing heavily on the industry's own internal documents, and worth a read. A meeting was held at the Plaza Hotel in New York of the council, legal teams of the tobacco industry. A strategy was elaborated that led to the Frank Statement, which you can see has a trial exhibit on it. It's now appeared in many courtrooms, that says the tobacco industry does not think that its products are injurious and that they will always cooperate with those who are responsible for public health. And of course, the opposite followed, leading in the end to the Department of Justice litigation and the decision of Judge Kessler that, in fact, the tobacco industry had broken the law. It had broken our racketeering laws created to deal with organized crime. Unfortunately, this is an aside, other industries that perhaps damage public health have caught on to this doubt creation strategy. So here is that same figure now labeled. And you can see that in the United States, we peaked around 1960 per adult at about 4,000 cigarettes per year. That's 200 packs per adult, smokers and non-smokers. So those are the days when people were smoking maybe not one pack, but sometimes two or three. And you can see these factors that drove tobacco use down. The rise of clean indoor environments, nicotine replacement therapy, other approaches to smoking cessation, rising prices, control of youth access, and so on. And of course, we have continued decline. One landmark here was the 1964 Surgeon General's report. I have to acknowledge the Royal College of Physicians did have a report in 1962 that said that smoking caused lung cancer. But in the US, the 64 report stands out as a public health landmark. Our government going on record saying that smoking caused adverse effects. In my mind, one of the first systematic reviews. So here is the report, the press conference held on Saturday because of the concerns about the stock market. The report had actually been requested by President Kennedy. The committee that did the report, shown here, and again, these reports are the product of a large group working together, and Surgeon General Luther Terry holding the report. How many of you read the 64 report? It's available free online. 330 pages. It's a good read, still. So take a look at it, and it really lays out, I think, sort of a model of what a systematic review is about long ago. So all the reports are available online. So the key findings here, you know them. Smoking causes lung cancer, increases mortality. And then this very important conclusion up here. It's a health hazard that we should do something about. And the model for the reports has been to lay out the scientific foundation for action while not necessarily saying this is what should be done or this is what should be done, but laying out the rationale or reviewing the policy options in later reports and saying, here is what might be done. And I think, again, looking back to these sort of, quote, good old days, we had this evidence to action sort of paradigm framed by these reports, synthesis of the evidence, pulling out those findings that would be policy drivers and taking action. I'm going to talk about one particular, the example of secondhand smoke momentarily. So since then, since the '64 report, there have been many, and again, all available online, 33 reports to date. And I'm going to talk about those related to clean indoor air. It's just sort of the example of moving to policy from science, and pause a little bit on the 2014 report, the 50th anniversary report, and now the 2016 report was on electronic cigarettes and youth, the last one to appear. So if I asked anyone here, first Surgeon General's report, all right, Richard, you'll have to be my volunteer victim. The first Surgeon General's report to mention secondhand smoke. Does anybody want to help out? 80s. Which one? 86. Nice try, but wrong. Okay, I'll let you all off the hook. 72. 72. And if, again, you probably haven't looked at it, but there's actually a chapter here on what was called tobacco smoke pollution. Worth a read, because even by 72, there was enough data on, heavily environments where there was heavy smoking going on. And so Jesse Steinfeld, the Surgeon General, then was the first to call attention to this issue. Okay, 86, good guess. Okay, so 86, the report with Surgeon General Everett Koop, perhaps well known to many of you. Here's our team. Everett Koop lived on the NIH campus, and here we're going to visit him. He actually had surgery almost immediately prior to the report's release, and we're going here to brief him. And here he is, just this unmistakable man. So let me tell you about one little anecdote. So he was very attentive to what we were doing as we developed the report. We had a meeting in Dallas at the airport, and those are the days when there were smoking sections and non-smoking sections in the airport. And here are two teenagers smoking. And Koop goes up to them and says, put out those cigarettes. And you can imagine this public figure coming up to the teenagers. They did. And this is some of the data we looked at. These are the epidemiological studies, sort of a primitive forest plot. But again, in terms of outlining the case for action, I think the report did it clearly. So here's the report, the first conclusion. Involuntary smoking is a cause of disease, including lung cancer in healthy non-smokers. Conclusion number 2, smoking by parents is bad for the kids, and lists out the bad things done. Conclusion number 3, simply separating smokers and non-smokers in the same airspace does not provide protection to the non-smokers. Okay, so take conclusion number 1 and conclusion number 3. There's a rationale for action. There's a direction towards policy. It's not put a line down the middle of the room, smoking over there, non-smoking over here. It doesn't say use filtration. But the argument, I think, lies there then for banning smoking indoors. And so again, this is the sort of the way these reports acted to affect policy. I think the model remains very, very useful, which is why the Surgeon General's reports move on, or you develop reports here nationally. So this authoritative review, rather, with laying out the science foundation for action. We went back to the topic in 2006, so 20 years later. This is a report I edited, And the bottom line is in that last sentence. In the course of the past 20 years, the scientific community has reached consensus. And this was sort of the saying, look, stop creating doubt. It's done. Scientific communities are at consensus. We have conclusions that are powerful in terms of motivating action. And I think actually I was gratified that within days of this report being out, it was being used in state legislatures to push smoke-free. So the model, I think, worked. And remarkably, in 2014, when we looked at the evidence on health, we added stroke for passive smoking and 7 or 8 new conditions caused by smoking under active smoking. And in the US, and I think worldwide, the impact was huge. So a map of smoke-free laws. In the United States, we do not have a national smoke-free law. Okay, so there's no national smoke-free law. It's done by states, municipalities, and it's very unusual these days to be in a place where there's actually smoking in indoor environments. So, on to 2014, and I want to take you there so you can see some of the discussion about policy and where the evidence is. We released this 50th anniversary report at the White House to have that sort of additional cachet for it. We didn't quite get to the 50th anniversary day itself, but here is the release. Secretary Sebelius, Tom Frieden, head of CDC, and Boris Lushniak, who was the interim Surgeon General at the time. Howard Koh, a longtime friend, Assistant Secretary of Health, and passionate tobacco control figure. And the release, and it's available on YouTube should you want to see it. Boris was spectacular. He read the major conclusions. And after each one, he said, enough is enough. And his point was well made until finally I wanted to say enough is enough with enough is enough. But it worked. And I want to highlight just a couple of the conclusions. So this one I thought was important, and one that could be told given the litigation. The facts were there, that the industry, of course, was the upstream driver, and that it had been aggressive and misled the public. In our legal system, fraud had been committed, collusion. So that was an important conclusion. There were others that I'm going to skip, but here we talked about the disparities in tobacco use. I know an important issue here, and one that just sits with us still in the United States. Tobacco use is among the major drivers of health disparities. Clearly, there are others. The fact that we have approaches and that we can still make gains, and that second line, with using what we already know. And then the third conclusion, dealing with combustible cigarettes. And I know, again, this is something you're working on. If you haven't looked, at least from the US perspective, there are comprehensive reviews of different policy options. And these are laid out not only in lengthy chapters, but in appendix materials. And we have conclusions about them, but I think most important was that we should do better with what we know. And there was this vision towards the future that I think where we went through some of the same ideas that you're looking at now as you hope to achieve a true smoke-free country. And those messages are here. I want to highlight that in the report, even though the electronic cigarette and other e-devices had not reached the point it's at now, I think we usefully anticipated sort of the policy issues, the policy dilemmas, and I'll come back to this, around non-combustible products. And in the US, we have the complication that you don't have of the Tobacco Control Act and subsequently the deeming rules that FDA has released, by which it will take authority over electronic products. So a goal of rapidly reducing combustible products use, and again, FDA holds the option of reducing nicotine content just not to zero. So I'm going to move on then from sort of the days of evidence accumulating action, particularly about the health consequences, to the FDA story a little bit. Now, the FDA story goes back to when David Kessler was the FDA commissioner. David had access to some industry documents. He saw the tobacco epidemic as one that originates in childhood. He thought it was an epidemic that needed to be addressed by the FDA, and he tried to do so. The end result was a legal case brought by the tobacco industry that went to the Supreme Court of the United States. The decision was from the Supreme Court that when the FDA was created, when the Food, Drug, and Cosmetic Act was originally passed early in the 20th century, that the intent of Congress had not been to regulate cigarettes. So that with the existing act, the FDA did not have the right, the jurisdiction to cover cigarettes. The consequence was then the passage of the Family Smoking Prevention and Tobacco Control Act. Another motivation, in fact, at the time was the Kessler opinion from the Department of Justice litigation about the actions of the tobacco industry. I showed you this earlier. So in 2009, President Obama signed the Family Smoking Prevention and Tobacco Control Act. And this brought an important new player into our landscape in the United States, the FDA with national regulatory authority. So here's what it does, and I'll see how much of this, I'm going to highlight a few things. I have a whole lot of material that follows about section this and section that. We're going to skip through, don't worry. Anybody who's ever read a federal act, maybe the same in New Zealand, should recognize that they're completely unreadable by ordinary people. And as much as I've struggled with reading the act, I've had my challenges, but broad goals here, preventing youth and helping adults to quit, and developing the science base for regulation of something we are contributing to, as are others, through our Tobacco Center of Regulatory Science. So a very broad authority. The authority is within the FDA is such that the act does not cover cessation. That sits elsewhere with therapeutics. So it does not cover cessation. And there's a few things here I will highlight that I do think are important. So one is this idea of making an application as a modified risk or exposure tobacco product. So tobacco manufacturers can come to FDA and apply to have their product labeled in some way as a modified risk product. So far, full applications have been submitted. One by Swedish Match for snus that has been partially reviewed. The other now by Altria Philip Morris for their, what in the US we're calling ECOS product, the heat not burn product. And these are massive submissions that have science, they have all the references, the documentation. Because of the population impact concern, there's modeling at the population level included with these. And I think in terms of useful outputs from FDA for you could be the result of these reviews and how FDA responds. So that's something to take away. FDA can set performance standards. It has set one standard so far for levels of tobacco-specific nitrosamines in smokeless tobacco. It does require reporting of ingredients on an annual basis. That's being done. The FDA tried to move forward with new warning labels and was blocked in the courts, okay, and has not yet come back with revised labels, advertising and promotion restrictions, user fees. In fact, the new Center for Tobacco Products is supported by user fees from the tobacco industry. I think I have the figure right, that the user fees at peak, which they are now, is at $750 million per year. to support the Center for Tobacco Products and its activities, which include public education, retailer education, research, and other things. So, Section 904, there's no test. Section 905, 907, see they're in order. Important to note here, it cannot ban something on the market. It can reduce nicotine yield, but not to zero. Not to zero. So Section 910, this is important to the e-cigarette issue. An application for marketing order is required for a new tobacco product unless the product has been found to be substantially equivalent, which is an FDA term, to a tobacco product already commercially marketed. This has gotten to be an important sentence for electronic cigarettes and what is the so-called predicate date by which a substantially equivalent product had to be on the market. And this has to do with whether electronic cigarettes are a new product or are not. There are forces that would like to move the date forward from the 2007 date that was originally prescribed. This is one of those issues where you can see the political influence of the tobacco industry coming in with a bill sponsored to actually change the predicate date about 1.5 years ago. And then my understanding is there's a rider on our agriculture bill that again addresses this. So in part, this is still sort of business as usual. So, and then the modified risk tobacco products, which I discussed. So Section 911, user fees. You can see there's a lot of stuff here. Okay. So one other important issue, and I'll take you through this a little bit because of what we did on menthol. So the Act called for the formation of something called the Tobacco Products Scientific Advisory Committee. It gave that committee a number of jobs and tasks, one of which within 1 year of formation was to look at menthol and its public health impact. So when the Act was passed, it banned all characterizing flavors. So you could not have, let's say, strawberry cigarettes. Menthol cigarettes were allowed. So menthol was the only additive as a characterizing flavor allowed. Menthol was equivalent to most of the business of Lorillard, tobacco company at the time, which made Newports among other cigarettes. And I'll come back to this because the committee was charged with doing this report within 1 year, and I think our methods are probably useful. So what has the Act done? So FDA has a new large center with probably 600 or 700 employees now. There's a research program, and substantial monies are coming from FDA to the National Institute of Health for the Tobacco Regulatory Science Program. It has released the deeming rule by which it takes regulatory authority over a number of products not covered in the original Act, including electronic cigarettes, which is simply not an issue in 2009. It has the 2 MRTP applications. It is working on it has released a product standard for smokeless tobacco, and it has various enforcement and public education activities. They've had a campaign, the Real Cost campaign, if you've seen that, which comes from FDA. So to the TPSAC, so the committee was charged with examining menthol cigarettes. We were given a task. We had, by the law, had to release the report within 1 year after the committee was formed. This is me up there in the corner about to jump off the staircase, I think, because I've realized the enormous task that I've gotten myself into. The committee actually met 8 times over this year to develop the menthol report. So here is our requirement. We're supposed to look at the impact of the use of menthol cigarettes on public health. Okay, and we had this broad mandate to look within specific groups. So what do we do? And again, this is where perhaps there's some things here that are useful. We thought about a framework to do our work. We said, how could the existence of menthol cigarettes compared to the, I'll use the epidemiological word, counterfactual, make a difference? So the question we had to address in terms of impact was, because we have menthol, what is the harm or benefit compared to the way the world would have been had menthol cigarettes never existed? So that was the question we had to explore. And this was our model. And the numbers like 1, 2, 3, 4, 5, and so on corresponded to parameters ultimately in our model, but also areas in which we did literature reviews. So we set out a framework for doing the review. We said, here's how we're going to gather evidence. We said, here's how we're going to model. We said, here's how we're going to evaluate the strength of evidence. And we sort of went back to the concept of equipoise. And if the evidence was sort of at equipoise, balance, or above or below, that was sort of our dividing line on how we dealt with the numbers here. We were assisted in our modeling work by David Mendez, who some of you may know, at the University of Michigan, and essentially built a model mirroring what I've shown in this figure. And here is the sort of main overall conclusion. So menthol cigarettes have an adverse impact on public health in the United States. There are no public health benefits. And then this conclusion. Removal of menthol cigarettes from the marketplace would benefit public health in the United States. So that was our conclusion. It was interesting. So Lorillard, which makes menthol cigarettes, Newports, what would be your guess as to what happened with the stock price of Lorillard when this conclusion came out? Up or down? All in favor of up? All in favor of down? So you're all wrong, you downers. It went up. And the reason it went up quite steeply, in fact, and the reason was we didn't say ban. And again, this goes back to this issue of, what do you do around policy when you're coming at building the scientific foundation for action? So, from my way of thinking, there might be a number of ways to do this. You could gradually reduce menthol. You could take it out. You could set some threshold concentration, whatever. Turns out that menthol is in most cigarettes. Probably for a reason, but not as a characterizing flavor. So we tried to present that. We ended up in an exchange. How many of you know Michael Siegel at Boston University, who sends out a daily message about tobacco, usually saying that someone is stupid, and that he's very smart? So Neil Benowitz and I had this exchange in the New England Journal of Medicine with him. He saw it as a lost opportunity. We saw it as one where TPSAC had done its job and laid out the case for action and for benefiting public health. Now, in terms of things that FDA has not done, it has not taken action on menthol. Okay, and we'll talk a little bit. Some of you may know that San Francisco is now moving to ban menthol cigarettes, about the potential for continued action at the local level. But, again, in terms of the general approach that our committee took, the modeling results, the addressing the overall impact, and then there's modeling for specific population groups, I think we did our charge. I won't go into the ensuing history of this report, TPSAC, litigation, and so on, but there's a long and complicated story that follows. So how about this for a topic? Again, in the old simple world, of course, electronic cigarettes, e-cigarettes did not exist, and now we have them. We have them in many different forms, of course, and the technologies are continuing to evolve and change, which I think challenges those of us who do research. And when I talk about doing research on this, I say we have to be on a different time frame to address things. So you study good old lookalikes, sig-alikes of 5 years ago, and people say, well, what's the relevance of that to now? Now we have, third and fourth generation devices. You can customize them. So we need to sort of up the pace of what we do, up the pace of looking at questions. I think those who are tracking tobacco product use have to be really on the ball about what is going on so our surveillance tools don't fall behind, which they certainly have. And we need to have the results almost available in a way, real-time kind of way, so we can do things. I love these images. If you go on the Tobacco Free Kids website, you can see the campaign for Tobacco Free Kids. You can just see these spectacular displays of what the industry is doing in its advertising. In the US, we did a set of CDC grand rounds about a year and a half ago, and Matt Myers from Campaign for Tobacco Free Kids showed this, and some of this is stolen from Matt, but just the uses of imagery dating back, of course, to what we used to see 30, 40, 50, 80 years ago. Could that be Virginia Slims from the 70s? Yeah. Marketing the specific groups. And of course, the use of menthol among African Americans is a direct outcome of very, very targeted and image-related marketing. I think this is about sex, which has always been a selling point, of course. And this one, I think you can figure out. Okay, and of course, you know, this turned out to be one point of struggle because all the clean indoor air legislation written in the 80s, 90s, early 2000s did not address electronic cigarettes. And I actually can remember a couple of years ago people vaping on airplanes, which is now, of course, specifically prohibited, along with do not put your electronic cigarettes in the suitcase because they explode, which is not good either. Did anybody see the 8 or 9 months ago, the series of case reports in the New England Journal of Medicine about injuries from exploding electronic cigarettes? If you haven't seen it, go take a look. If you're puffing on an electronic cigarette and it explodes while it's in your mouth, it can do a lot of damage. So the gory pictures are there if you want to use them. Okay, and then still advertising on TV, something that many of us had not seen for a long time. Blue, for example, and then the rise of the vape shops, which I gather is sort of starting here as well. Figures of 35 to 37,000 vape shops in the US. They're all around our college campuses, big surprise, and you know, sort of offering this ambiance of comfort, culture, and so on. So you could get instructed here in what you might want to sample, what device you might want, what coil you want, and so on. And again, someone can easily spend a couple $100 developing a device. And then one of our major concerns, flavorings. And of course, these are not the flavorings that a committed adult 50-year-old smoker would be looking for, like e-liquid cotton candy. Might be for somebody younger. And one of our concerns about the flavoring is the inhalation of the flavor. So this is an editorial we had in the Journal of the American Medical Association a couple of years ago. Turns out that one of the flavorings still present, I think, is diacetyl, which is a widely used flavoring in foods for sort of a butter-like flavoring used in microwave popcorn, for example, which is where the problem of popcorn workers' lung was first identified. You may know the story of workers using this flavoring in bulk as they mixed it to make butter-flavored microwave popcorn. Some of them developed a sometimes fatal lung disease of small airways of the lung, bronchiolitis obliterans. That same flavoring is now, and some similar molecules, in liquids being inhaled through a very effective drug delivery device by people, perhaps starting a young age, even while the lung is still developing, and perhaps inhaled across a lifetime. That worries me. That worried us, and that's essentially what we said in this editorial. And there's been some papers out that you might look at on sort of what flavorings are in various e-liquids. Now, Also important around kids is the consequences of using electronic cigarettes for future combustible cigarette use or other tobacco products. And this is another paper we published in Journal of the American Medical Association about 1.5 years ago. Adam Leventhal led the effort in a cohort study of young adolescents who were tracked at 2 time points. And we looked at e-cigarette use at baseline as a predictor of future combustible cigarettes, and about a 3.7-fold increased risk. We also looked at combustible cigarette use at baseline and future e-cigarette use. Can you follow that? Okay, you're not jet lagged. Okay. All right. So, and there was the same risk. And, you know, my ideas about sort of gateway, which I think simplified is one thing leads to another, have become sort of displaced by the idea that this is very complicated around individual susceptibility and paths and trajectories that are potentially malleable and that are changing. So there are now other studies of this sort, 5 or 6 or so, and we're continuing with our work. There's a meta-analysis that I think might be published now, taking the different cohort studies and pooling them. And this is the pooled estimate. I guess you can't see that. The 3-fold bottom line summary estimate is pooling for the risk, estimating the risk of future combustible cigarette use given e-cigarette use at baseline. Okay, so a 3-fold increased risk in this meta-analysis. So there it is. And then we have a recent paper out basically saying that youth who use these have more respiratory symptoms compared to non-users. And this is just out of one of the respiratory journals. Now, so what is happening? This is data out about 1.5 weeks ago on cigarette use in high school students and other tobacco products. If you look out at any products on the left, my right, your left, the drop in 2016 is apparent. There's a drop in e-cigarette use, and there's a drop in cigarette use. So is this good news? I hope so. I think we have to wait for next year and make sure this is not one of those things. But the point I make repeatedly is that this story is in motion. And again, the contrast is to good old combustible cigarettes alone. So there's e-cigarettes and that drop. Okay, so the other piece of stuff from the US is the deeming. And this is FDA taking authority over e-cigarettes, cigars, some other products. The rule is out and official, but not yet implemented, and caught up in this controversy about the predicate date for electronic cigarettes, among other issues. Premium cigar manufacturers fighting back, saying all cigars should not be covered. Premium cigars should be omitted, whatever a premium cigar is, which is a definitional problem. And then this is sort of what is done. Flavorings are still allowed. Flavorings are still allowed, and you'll notice that advertising is not restricted. So we remain concerned. The 2016, sorry, not the 2018, the 2016 report, the Surgeon General was on youth. And again, I was involved here in the policy chapter and made the points that we just discussed, that this is in motion, that we need to be very careful and watching what is going on. And there are the conclusions. Again, another report available online. So in terms of where we are, there's a great deal of need for research. This comes from a workshop we did at National Institutes of Health a couple of years ago to try and look at the research agenda around health, and identified many key issues. And I want to look at this from this perspective, and something we were talking about earlier today, which is we begin to line up harms and benefits. Who benefits potentially? who is potentially harmed. So the potential benefits for current smokers who, by switching to e-cigarettes, arguably reduce their exposure to disease-causing toxic agents, and they might also reduce or quit smoking. And in result, ending up gaining DALYs, if you will, gaining life. And on the other side, harms. For youth, so nicotine exposure to the adolescent brain, not good. Risk for becoming users of other tobacco products, slowing cessation, pushing former smokers back to nicotine addiction because they decide that, hey, I've stopped smoking, but I can get nicotine now safely, and perhaps there's one pathway of going to electronic cigarettes, and then perhaps lapsing back to combustible products. And the potential to renormalize nicotine exposure and smoking. And again, at least in the US, if I talk to our undergrads or talk to high school students and say, how many of you have been to parties where there's vaping? Everybody raises their hand. Okay, so that's where we are in the US. And just one other point, you don't have to just vape nicotine or flavorings, you can vape THC. Okay, and so now we have this new concern about sort of an emerging dual use pattern of marijuana and tobacco/nicotine. So where does this balance? And again, this is just what I showed. And I think the point that is missed in this debate, well, these people benefit, and what about the kids? This is really sort of an intergenerational risk trade-off. And so think about it. What is the calculus for saying, okay, we're going to benefit older smokers of cigarettes? We face the risk of harming adolescents and young adults. How would you make that trade-off? So how many do you benefit versus how many do you harm? Well, of course, that answer is very complicated and depends on who you ask. And I feel that those who are sort of making some summary of DALYs gained on one side versus DALYs lost on the other have missed the point. And that this is a far more complicated risk trade-off. Okay, so in the US, we have this sort of monolith now of FDA and states doing innovative things. Tobacco 21 in California. We have San Francisco to end the sale of flavored tobacco products. Guess who is likely to litigate about that? We have the states and municipalities moving forward on smoke-free environments to cover electronic nicotine delivery systems, and states looking at sales to minors. Okay, I have 10 minutes left. I've done pretty well. So I'm going to say just the word third-hand smoke. Ring a bell for anybody? All right, so 2 minutes on third-hand smoke? Okay, 2 minutes on third-hand smoke. So we've been part of a consortium of investigators in California addressing the issue of so-called third-hand smoke. And this is a paper that came out, I think, just early this year that covers the work of the consortium. Okay, so if you want to find out more about it. So this is sort of complicated definitionally. So here is a definition of third-hand smoke. Third-hand smoke consists of residual tobacco smoke pollutants that remain on surfaces and in dust after tobacco has been smoked, are re-emitted into the gas phase or react with oxidants and other compounds in the environment to yield secondary pollutants. Got it? It's not a very sort of implementable definition. So what is third-hand smoke versus second-hand smoke? So in this world, if you say that there's something called third-hand smoke, then second-hand smoke would be the stuff that is in the room while smoking is going on, at least the particles suspended in the air, the gas that's there. Stop, smokers are gone. Now you have third-hand smoke. Okay, so third-hand smoke would be the surface deposited materials, the stuff regassing into the air. There's a lot of chemistry here, and the stuff from the tobacco smoke reacts, for example, with ozone and nitrogen oxides, makes new compounds. The concern, and you all know about secondhand smoke, third-hand smoke. You get in an elevator with somebody who smokes, do you smell them? Yeah. You move into a room where people were smoking, you smell it. That's what is being called third-hand smoke. The issue from the policy point of view is, how should this be handled? So if you go to buy a home where a smoker has lived for 30 years and the building materials and carpets are saturated, what do you do? And how do you manage it? Should it be covered, for example, by disclosures at the time of sale? Rental cars, clearly, at least in the US, are all going to smoke free. So we've tried to look at this from the policy point of view. Our colleagues are looking for markers of third-hand smoke and trying to understand whether there's any differential toxicity compared with our usual friends, secondhand smoke and mainstream smoke. So that's what this is about. And I think I won't say any more there. I'm just going to fast forward to one last thing and just say what we're doing in our tobacco-centered regulatory science. So we have three main projects. We have a focus on diverse populations and tobacco. We are in one project looking at social media, looking at the transmission of messages to people and website presentations based on who they are by age, sex, and ethnicity and race. We are looking at social media, Twitter and Instagram particularly, and the messaging there, and key opinion leaders and the messages they give. We're looking at the retail environment in different kinds of neighborhoods and have a protocol for doing that. And then the project I've labeled epidemiology is looking at trajectories of tobacco use across adolescence and young adulthood. In our pilot projects, we have one on sweet flavorings and abuse potential, abuse liability. We have one on respiratory risks of electronic cigarettes and flavorings. And we also have a training program in tobacco regulatory science. And happy to share any of these materials. So let me stop with 6 minutes left. Hopefully there's a lesson or two here, if not in what to do, in what not to do. Good luck with your projects, and I look forward to seeing what happens by 2025. And thanks very much for the invitation to be here.
Okay, we've got some time for questions, and then for the people who are online, if you want to type in questions, we can relay those on. So, Tony, right at the back.
Yeah,
Hi, Tony.
Thank you, great presentation. We're just about to go into our own meeting with our own e-cigarette model, which is giving us a hard time. You gave the odds ratio of 3.2 for the increased initiation amongst youth who use e-cigs. But conversely, as you also said, they're probably the people who are more likely to smoke anyway. And so us modelers need to lift our gaze to what the population level effect is and then put it back down to the individual. So there's many questions I could ask. I'll just ask one. If you were to think about young people and old people and what that net effect of e-cigarettes might be on cessation across everybody, what's your best guess or what's your best evidence at this point? Because we're struggling on this.
Yeah, I'm struggling right now because you asked me the question. You know, I mean, fair enough. I mean, the problem, of course, is that there's not really very good evidence to decide what the model parameters should be, which I think is what you're getting at. The cessation literature is so limited. I commented earlier this morning, we've been doing a review of the reviews. I think we've identified 10 or 11 systematic reviews of electronic cigarettes and smoking cessation, when, as you know, the solid studies are far less than 11. So, you know, I suppose if I were making that guess, I would, if I were forced to pull a number out because I have to do a model, I would probably go back to the NRT literature and use a figure from there. I don't know what you're doing, but yeah, I mean, it's sensible, isn't it? And you could say, well, you know, we're giving nicotine by yet another route, and perhaps somewhere in that range might be the efficacy of electronic cigarettes. On the kids side, we have some other paperwork I didn't show you where we tried to sort out sort of endogenous susceptibility. and how that might drive starting point, electronic cigarettes or combustible cigarettes. Of most concern in the most relevant analysis, those children who buy our instrument are less susceptible, have a higher risk of moving from electronic cigarettes to combustible. So that parameter to me is a little more difficult, and I think you're sort of left with making some reasonable bounds. I mean, the point estimate from the meta-analysis is probably the best overall shot at this, but it doesn't help you with who is in the at-risk pool for that particular relative risk. So I think, having heard me struggle, I think you are justified in making some reasonable assumptions based on these little threads of evidence we have. The transportability of these estimates in space and time is, of course, another matter that I think you'll be left with as a major uncertainty. Yeah, it's hard.
Can I just, since it's not hand up, can I just ask a question? You've talked about menthol and additives, and in terms of product modification, if you were looking at introducing some sort of regulation to reduce the appeal, reduce the effectiveness of cigarettes as a sort of delivery device and as getting people addicted and helping people to quit and so on. So there's lots of ideas. There's getting rid of menthol, there's getting rid of other additives, there's getting rid of the filter ventilation, there's removing filters. What would be your sort of best buy at the moment?
Well, I mean, I think the easiest answer to the question, and I think TIPSAC answered it, and the pharmacology answers, is get rid of menthol. And you know, the menthol story, if you don't know it, I mean, methylation of cigarettes was a serendipitous finding, and it couldn't have been better in terms of the pharmacology of menthol and what it does with both its sort of local anesthetic properties and possibly some complicated pharmacological interactions with nicotine. So, you know, as a colleague in California says, it makes the poison go down, and at least in the US, there's been rising contact with menthol among new youth smokers. So menthol to me is the easy one, and that would be, as I mentioned to you, there seems to be some menthol in all cigarettes, would be to just ban menthol altogether, and I think that's the easy starting point. The question of filter ventilation and what it does and doesn't make a difference, and questions about adenocarcinoma, which have risen recently, is a more complicated matter in terms of product modification. I'm not sure that I, have a clear answer. I mean, the problem is if you heat a rich organic mixture to 1,000 degrees centigrade, you generate toxic products. And as long as that's the principle underlying the cigarette, it's going to be very, very toxic.
Shane.
Good, thank you very much. Good, thank you very much. You had a point at the start which I don't think you had time to comment on, which was around the industry rejuvenation. You talked about the golden era. I think you're right, the golden era was created, I think, because of the evidence and the research, but also equally because of the legal challenge that was done primarily through America at the start. And the rest of the world actually got to live off the fact that the industry was proven to be high and deceitful. I think recently it's sort of been very quiet as an industry. It's coming across as, again, as trying to be a responsible industry. Recently, The Guardian sort of report has shown perhaps that it's still an international level, it has a necessary change in spots. I'm just trying to respects of how the work which you're doing, which is really important, but actually I do think how we need to somehow keep on shining the light on the industry's activities and the importance of that and the lawmakers, particularly in the states, who've got a very strong lobbying group over there, but also the wider public opinion, because the generation of smokers now didn't grow up with seeing the sweating and the blatant line in this report. I won't have any comments around that.
Yeah, so I mean, there's, the industry is alive and well in our country in terms of its ability to move in Congress and have impact. And, you know, again, around the deeming rule, the predicate date, that's been very well shown and documented, and they still continue to try and influence things at the local level. I mean, I will say I was very active with the city of Los Angeles as it moved to change the clean indoor air laws to cover electronic cigarettes, and there was a lot of industry pushback in LA, New York, Chicago, you know, sort of the major cities that were leading the way on this. So I mean, given what a $100 billion plus industry, it's not going away, and it's going to continue to do what it does, which is to make money. Somewhere, Wall Street Journal, a month ago, there was an article about sort of this, not only is the industry alive and well, its profits are going up. And they've been able, in the US, as taxes have gone up, they've tagged on a little bit extra. And this piece pointed to the fact that the profits just continue to rise. Robert Proctor has figured something like if you had invested $1 in, at the start of the last century in tobacco, you'd have $1 million now. And it's remarkable for how this industry just keeps growing. And you know, now we have 2 companies in the US. So there's this increasing centralization, which I think means more economic clout, which means that, you know, everybody has to be wary. But the other part of what you said was, you know, how do we continue to keep this out? And, you know, at this point, we've seen everything, haven't we? We've had the documents, we've seen their behavior, we've seen the executives lying before the US Congress, and so on. And I don't know what would impact the public next or get the attention of the public back to this, because we don't see very much about it anymore, as you point out, the way it used to be as these revelations came out in part through the litigation. So I think as things happen, we need the right journalists to help and work with us to highlight those things. And the you know, the Bloomberg Initiative has put a lot of effort into training journalists around the world, particularly in the lower and middle income countries, to try and do what you say should be done. I fully agree.
Okay, we've got one question from Gilo, is it? From on the screen. Can you read that out? And then maybe we'll take one more here, and then we better wrap up.
The question is, has there been much influence by tobacco companies in the US about supporting e-cigarette use, in quotes? If e-cigarettes and heat-not-burn products are part of the next phase of their business models, what do we need to do to prevent their influence on smoking cessation research and practice, which often appears to be overtly pro-e-cigarettes in New Zealand?
Yeah, so it's a complicated question, and obviously one that's place-specific, I think. And, you know, in the US, we have the rise of this vaping industry that seems to be more local in its origins, although it's not so well understood, with 35,000, 37,000, whatever, vape shops. With the vape shop owners and the vape shop imagery sort of promoting as anti-cigarette, in fact, and pro harm reduction. And then the majors coming along, all with their own e-cigarette products, and now the heat not burn product, with, I think, the potential for claims about health. At least in the US, a cessation claim cannot be made explicitly unless the proper clinical trials were done and application made to the FDA. I think in terms of the implications for researchers, this goes back a little bit to what I said before. The world is changing faster than we do our research. And I think, to me, that is a real challenge. And to do policy relevant research right now is really, really demands quick response. And some of the papers I've showed you, we have turned around very, very quickly, because if we didn't, they were not going to be relevant to thinking about the public health questions. Now, you know, I think so. You do a 5-year cessation trial, and then somebody comes along and says, "Great, nice trial, methodologically pure, wrong device. We don't use those anymore." So I do think there's a real challenge for us to think about quick designs that may get us to answers faster than we have gotten to before, maybe designs with surrogate markers, outcomes, but it's just not like where I started, the good old days.
Okay. I have one last question.
From video industry.
Yes.
The tobacco industry has a global marketing approach. Why don't the public health communities around the world unite in the same effort of smoke-free environment?
Well, haven't we done that in part? I mean, I think, clearly, even before the Framework Convention on Tobacco Control, I think a network had been formed of those around the world concerned with tobacco. I'd actually draw your attention to the book my colleague Heather Whiffley wrote on the FCTC and its origins, The Global War on Tobacco, published a year and a half ago, that talks about some of this, the rise of the movement, and then how, in fact, the FCTC fostered that as people joined together in its passage and now through the conference of the parties. And then, of course, on top of that, we have the Bloomberg Initiative, the money that Gates Foundation has put up, Empower, which includes, of course, protecting non-smokers. So I think there is a global movement, there's global sharing. Perhaps a different question is, how could we do it better, and are we doing things as powerfully as possible given new tools for communication? But I think we, really have progressed at certainly national levels in many countries and globally, and there's a lot of sharing. So hopefully we'll continue to do that. Great.
Okay, so perhaps if I could just finish by just thanking John for a wonderful talk. I think it illustrates how we need that sort of dispassionate, scientific, very critical thinking about some of these issues, which, as you say, are very rapidly evolving. But I think the thought that what you brought up about intergenerational trade-offs and things shows it's not just about epidemiology, and it's never just about epidemiology. But there's a moral and an ethical perspective, and as you've been saying, deep thinking about some of these issues that we need to do, as well as being very cognizant of the science and the epidemiology and the toxicology and all the rest of it. And I think you've illustrated that very well with some of these really big issues that we're facing. And I hope that this has really helped with our journey towards Smokefree 2025. I'm sure a lot of people here have got some new thoughts, some new ideas. I certainly have. So if we could just thank John once more.
Thank you. Thank you very much.